right, so welcome everyone. I'm Selena Gore, the CEO here at WomenHeart. And for those of you who are new to WomenHeart, we are the only patient-centered organization focused on the support, education, and advocacy specifically for women living with and at risk of heart disease. Our topic today is what women with heart disease need to know about contraception. We are so grateful that we have such a wonderful panel with us. Before I get to introduce them, I want to thank our funder, Exceltis. Exceltis has been a real champion in this space, and we want to present some information to our audience and community so that you think a little bit also about how this is relevant to you and your contraceptive needs. So, most people of reproductive age at some point think about contraception before they make their decisions about which birth control option is the right one for them. And women with heart disease and the risk factors associated with heart disease, like hypertension and smoking and obesity, as examples, like the factors that they have to consider are even more. So in addition to considering safety, effectiveness, and preference in contraceptive choices, you also need to know how each method may or may not impact your heart health and interact with perhaps the ways that you're managing your heart disease. And you'll also need to know whether it's safe to consider pregnancy at all, given what conditions you might be dealing with. So today we have some great experts to unpack all of that for us. I'd like to introduce first Dr. Natalie Bello, who is a cardiologist and the director of hypertension at the Schmidt Heart Institute at Cedars-Sinai in Los Angeles. We also have Dr. Kecia Gaither, who is an OBGYN and is board certified in maternal fetal medicine. She serves as the director of perinatal services and the director of maternal fetal medicine for the New York City Health hospitals in the Bronx. She's also an associate professor of clinical obstetrics and gynecology with Connell Medicine. We also have Kimberly, Connell, who is a WomenHeart champion from the class of 2017. She attended our Science and Leadership Symposium at the Mayo Clinic that year and joins us from hot Houston, Texas. She also is a heart transplant recipient. So that's going to make this, I think, conversation even richer to think about all the considerations we've got to look at. So thank you all for being here. Why don't we have Dr. Gaither kick us off? Before we dig into considerations about heart disease specifically, can you give us sort of a short overview about what types of birth control are currently available?
Okay, well, there's quite a bit of information and availability of the different types of birth control methods. So let me just run them down quickly. You have abstinence, you have the rhythm method, you have barrier contraception, you have calendar type of contraception. So all of those involve a very stringent detail to what it is that you're doing, when it is that you're doing it, and all of those that I've listed do have a high pregnancy rate. They're not as effective as what I'm about to discuss. Then you have your combination type contraception. And when I say combination, estrogen and progestin, and they can come in either an oral form with pills, vaginal rings, injection, or patches. Then you have your progestin only types of devices. And again, you can have those in oral or intrauterine type devices. And then you can have your permanent type of contraception, be it vasectomy, be it tubal ligation, be it there's a thing called Assure, where basically a hysteroscopic procedure is done to put these rings into the os of of the fallopian tubes. And then you have your LARCs, your long-acting contraceptions like your IUDs.
Great. That was absolutely a fast and furious tutorial. So I appreciate as I mentioned before, though, women take a lot into account when selecting, making their choice. There are side effects, there's the ease of use, there's access issues, and there's also sort of what is preferred, but importantly for many of us, what is affordable. We know that while the ACA requires no cost coverage for birth control, and obviously that has made it a lot easier for millions of people to access birth control, there's still so many that are uninsured. So the cost does remain a factor. So I'd love for you, Dr. Bello, to answer this for women with heart disease. What should they be considering? I should say I also have cardiovascular disease. What are we talking about when we say all women with heart disease? Or is it actually all women, or is it just certain women with certain specific cardiovascular diagnoses and risk factors?
Thanks. That is a great question, and one that I, as a cardiologist, love to answer and like to talk to my patients about too. So I'm really grateful to WomenHeart for this opportunity to sort of share some of this knowledge, so that people with and at risk for heart disease have the knowledge they need to ask their doctors, their healthcare providers about contraception. And really, it is shared decision making that should take place. So you sort of highlighted nicely, and Dr. Gaither highlighted some of the preferences that a patient, an individual who can become pregnant, needs to think about and discuss with their doctor. On the physician side, we think about different risks that might be associated with some of those different forms of contraception. So risk for thromboembolism or creating blood clots in the body is one of the greatest things that we take into consideration when we're thinking about the different forms of blood pressure. That's what I do most of my day, birth control. And on the flip side, bleeding profile. So people who are on bleeding medications that make them more likely to bleed, blood thinners, aspirin, Plavix, other medications like that, clopidogrel, other blood thinning medicines for people who might have stents. Those come into effect as well as, and Dr. Gaither alluded to this as well, the sort of adherence necessary and the dosing of certain types of are some things you need to take into account, like your calendar, other things, a pill every day versus the LARCs, the long-acting reversible contraceptives, where it's sort of a set it and forget it situation, where there's very minimal maintenance and upkeep with those. And the side effect profile for individuals, we know everybody responds to different medications differently, and having that conversation, if you start a new contraceptive, if it's not working for you, talking to your doctor as well. And so for me, a lot of what it comes down to for individuals who have heart disease already, and maybe I'll take a step back and sort of name some of the conditions that I think about most commonly that might have higher risks. So people who have maybe had a DVT, a deep venous thrombosis, or PE, pulmonary embolism. So those are people who've had a history of blood clots. Certain individuals with hypertension, especially if it's not well controlled, or if they're of older age. And I want to be sensitive, we say older, but say 35 to 40 or older, and still need contraception. Individuals with current or a history of ischemic heart disease. So that's history of heart attacks, angina, those sorts of conditions. Individuals who know they have a genetic mutation that causes them to clot more commonly. That can be things like factor V Leiden. And individuals with cardiomyopathies. So things like peripartum cardiomyopathy, individuals like Ms. Connell, who we're going to hear from, who have had organ transplantation, particularly for folks who may have had complications, smokers, and I know I think of that almost as a cardiac risk equivalent. So individuals who are active smokers have a much higher risk of blood clots, heart disease, and they go into that higher risk category. Folks who've had a stroke as well, and certain types of valvular heart diseases that have been complicated, and certain types of congenital heart disease as well that might have bileaflet valves. So folks who might have a Fontan circulation, folks who have cyanotic heart disease, and other people with left to right shunts who have higher risk of clotting are the folks that I think about really avoiding combined hormonal contraceptives in because of their greater risk of blood clots. And that's really the biggest thing that usually will dictate which way we're talking about contraception that is an oral or other hormonal contraceptive. But I'd love if Dr. Gaither wants to jump in as well, because this is certainly her wheelhouse.
Well, you know, when I have a patient who comes to me either for preconceptual counseling, or if she's already pregnant with an issue and we're talking about, okay, what are you going to do after the baby is born? There are things that we need to discuss. First of all, what type of cardiac issue do you have? Because that in a way is going to predicate how I'm going to counsel you accordingly. You know, if you're thinking about contraception as a whole, know that there are side effects. They are thrombogenic. They can impact patients that have arrhythmia. And again, one of the side effects is fluid retention. So if you have CHF, you know, we're not going to put you on a particular medication. If you have an atrial fibrillation, or you have something that's predisposing you to having a cardiac arrhythmia, there's certain things that you're not going to be on. You know, oral contraception that contains estrogen is thrombogenic. So, you know, if you have certain cardiac issues, you're not going to be a candidate. So I think one of the main take-home points is you need to have a cogent discussion with all three of your providers, your OB, your cardiologist, and, you know, if you have a PCP involved, to determine specifically what cardiac issue you have. And then after that, to have a discussion as to what birth control option might be best for you. Somebody with pulmonary hypertension, for instance, you know, we're going to be discussing permanent sterilization moving forward. You know, they are really not the kind of person that you want to get pregnant again, even though I have few in my practice, which gives me angina in and of itself, but that's another story. You have to know what you have to have a cogent discussion on what will be the best option for you.
Yeah, can either one of you sort of repeat the relationship? I want to be explicit here. The relationship between estrogen and heart disease. So we said it was thrombogenic. And for those of us who may not understand necessarily what thrombogenic means, well, can we spell it out so that everyone understands? Oh, yeah, I've had that thing happen to me, and you know that I need to make sure that I ask my OBGYN about it, because I do need to get on some birth control.
It causes blood clots.
So estrogen causes blood clots.
Particularly oral
It increases
estrogen,
your risk of it, yeah.
right? We think that there's something to do with the way that it is metabolized by the liver and makes your blood much stickier and more likely to clot. So if you've already have something that makes you predisposed to clotting, or if having a clot would create a greater risk to you, those are the types of cardiovascular conditions we're worried about using combined hormonal oral contraceptives in.
Great. Okay. And so when you have, I mean, it sounds like, Dr. Gaither in particular, you have patients that you have to carefully manage this with. And what do you say to them when they come to you and they say, yeah, I do have atrial fibrillation, for example? I mean, are there sufficient levels of options for them on the, for contraception, or, does providing a birth control method become really challenging?
I think it can become challenging depending on what it is that they have. If they have AFib, they're going to be on a blood thinner, and then you have to concern yourself with, what contraception option might be best for them that won't interfere with that. So it can be challenging. And it always, the decision always has to be in conjunction with the cardiologist, who can give the most and the most cogent and clear information as to what it is that they have specifically, and have a discussion with them, as to options.
Yeah. And it sounds like estrogen's a real culprit in this space. So are there good and effective options that don't contain estrogen?
You can have a progestin-only pill, which are good options. You can have your copper IUDs. You can have tubal ligation. Those are all cogent options to offer patients. And there's a new progestin-only pill on the market called Slind, which has some very nice benefits to it in the event that you forget to take your pill. There's always, there's a window where it's not such a big deal as it is with other birth control pills. So there are options, few, but they exist.
Exist. Yeah. It'd be, I think this is a great moment to hear from somebody who's gone through these very real and difficult and challenging thought processes and considerations. So I'd love to bring Kimberly into the conversation. Hi, Kimberly. Why don't we start with having you share a little bit about your heart story?
Oh, okay. My name is Kimberly, and I first was diagnosed with a heart murmur at the age of 12. And that kind of went on until I turned 17. And then I was diagnosed with hypertrophic cardiomyopathy. And then when I turned 21, I went into heart failure.
Wow.
And so this is like the elevator version. And when I turned 25, being on the list of a heart transplant was actually my second time. I got on a heart transplant when I was in my early 20s, and I started to get a little better, not really a candidate for a heart transplant. So I was taken off, which was a good thing for me. And then when I was 25, I was back on a heart transplant due to the fact that I ended up pregnant with my son. And at that time, my heart went down to pumping only 20%, and that was only on one side. And it led me to birth him at 26 weeks. And he lived for a month and 3 days. And so after that, that's when I had to return back to the heart transplant list, because at that point, that pregnancy had wiped my heart out.
My goodness. Thank you for sharing that. I mean, we're so lucky that not only are you here with us today, but you're here as part of the WomenHeart family to share this story and to help others, as they consider their own journeys, their own heart journeys.
Yes.
So can you talk a little bit about, given all of that experience with heart disease and heart failure and getting a new heart, what your experience has been in deciding which birth control method you would use, given everything that you're doing?
Yeah, that was a task, just to figure out what they wanted to put me on, because at that point, I really had no options. It was just like, well, I could put you on this, but it would affect this, or it could be at high risk for this. Well, no, let me try. It was just like trying to move through, and I pill form was just out of the question for me all the way. There was no way they would put me on pill form, and because of the estrogen. So I was limited. And when they finally found one, it was the Implanon, and I received it in my arm, and that one lasted me for 3 years. So we kind of like monitored me to make sure that everything was going well with it. And it did a good job. And then once I took it out, I kind of didn't have, birth control for a while, just trying to, get back to what was the best option. And that's how, between that time of trying to figure it out, I allowed myself to become pregnant. So that's how that happened. And it was tough, just trying to go through with a pregnancy and manage heart disease. It was a very dark place. Let's just say it like that. It was very dark. Just trying to, I had to have shots in my stomach to make sure I wasn't getting like blood clots. It was just a whole process. So after that pregnancy, I had to get back on birth control, and I did the implant again. But the second time, I bled for 11 months. And it was like, no one can understand, why are you bleeding? And I'm like, I don't know. I didn't know I was going from OBGYN to OBGYN. And I finally went to my old OBGYN. I went through a transplant, bleeding, everything. I was still on my cycle. When I came out of my transplant, I never stopped bleeding. And I went to my doctor after the transplant was done, and I told her I can't stop bleeding. She started walking me through, well, maybe we should put you on birth control. And I say, well, I'm on birth control. And she said, well, that's the problem. And I had to schedule an appointment to get the implant taken out. And the moment that I got it taken out, it's like my cycle dried up. So I had a great experience with it. And then I also had a bad experience with it. So it was just still trying to figure it out up until now. After I had my daughter, I had birth control is still a thing that I need to be on, even though I'm transplanted. And now I can't remember the name off the top of my head, but it's like a gel now. So it's kind of like easy for me because the implant wasn't the best experience at that time. Do I think that I can try the implant again? I do. But at that particular time, I think my body was just going through so much, just like from one stage to another. And so I'm back on birth control now. And I really can't think of the name of it. If it comes to my head, I'll say it. But it's gel form. And so far, it's working pretty good for me.
Great. I mean, gosh, I just sort of felt like I went on an emotional roller coaster with you listening to the story. It's a lot. It's a lot to go through. I mean, what would you say to, let's say, a woman who's been newly diagnosed with heart disease and is considering her birth control options? Like what kind of tip would you give her given all that you've been through?
My only tip to her would make sure she has a good relationship with her doctor and really communicate everything that she's going through, so that doctor can know exactly how to give her the birth control that's suitable for her. Because one OBGYN couldn't figure it out, while I went to another one and she had exactly what I needed. So I would just say communication and relationship with that particular doctor that you're dealing with at that time, or if you need to change, because you have to have the right birth control for you.
Yeah. And Dr. Gaither mentioned earlier, making sure that your 3 providers are on the same page. So when you were talking to your OBGYN, were you also able to get some counsel from your cardiologist? I mean, were they talking to each other? Because I feel like that, was there opportunity for that to happen?
Yes, they were, but at the time, my doctor was Dr. Myers at the time. So once she put her trust in an OBGYN that I had, she believed that she would make the best choice for me. So once they had that one conversation, she was content that she's going to make sure you get what you need. And I trusted my doctor because, she trusted her, and I trusted my doctor for trusting her. So we just went with it, and we eventually found the implant, and it worked.
Fantastic. That's great. Dr. Gaither, I want to come back to you, because I'm sure that Kimberly's story is not unique in stories that you hear from your own patients. What are some what would be some of your guidance to women who are going through similar journeys, sort of, having to navigate not just being on birth control, but then thinking about, okay, I've got, multiple comorbidities, multiple health issues that I'm dealing with. How would you advise them in terms of maybe, asking the right questions of their doctor, and, what sort of the right, follow-up schedule, let's say, given that, many of these things may take some time to show up, from a side effects perspective?
Again, getting a good history. You know, you said that you had hypertrophic cardiac disease. So, you know, some cardiac disease has a genetic component. So getting the genetic counselor involved in the conversation to see if indeed there is a genetic component. A lot of times, depending on what mother has, there's a 2 to 3% chance that baby might have it too. So getting, you know, pediatric cardiologists to do a fetal echocardiogram to make sure a baby doesn't have anything. You know, with Mrs. Connell, it sounds like a real interdisciplinary team was needed. Certainly the cardiologist, certainly the coronary intensive care unit, and the cardiologist hopefully would have been an interventional cardiologist. Geneticists would have been involved. Certainly a maternal fetal medicine specialist would need to be involved. So again, it all comes down to what kind of cardiac disease is this? How is it presenting? What are the best options? And ensuring that you have a multidisciplinary team with everybody talking to ensure that we have the, you know, the best outcome for
Yeah,
mother and baby.
thanks for that. I see we've got a question that's come in, and I think, you know, either doctor can maybe take a stab at the answer. The question is Plan B bad to use if I take heart disease medication?
So Plan B is one of, and Dr. Gaither, please jump in at any point if you want to correct me, but one of 3 forms of emergency contraception that are currently available in the United States and are considered actually safe for all cardiovascular conditions. So the CDC gives us sort of a ranking of from no contraindication to completely don't use it. And for all types of cardiovascular diseases, what the medication that's in Plan B is considered class 1 to 2, depending on the condition. So class 1 is no contraindication, and class 2 is that potential benefits outweigh the potential risks. So in general, and you know, I don't want to talk specifically because if there are combinations of conditions, perhaps the risk benefit profile would change. But in general, it should be used within 5 days of intercourse. We know it's most effective in the first 3 days after unprotected intercourse. The other thing I will also add is it's less effective for folks whose BMI is greater than 25. So again, if you're somebody with heart disease where pregnancy can be very risky, thinking about a more consistent form of birth control with a low failure rate would be a better option for your health.
Absolutely. You know, it's an interesting thing that you bring up, because I think, you know, I shouldn't say young, but people in general want to manage their sexual lives on their own, right? That feels like that's a pretty normal thing to do. But in this case, when you are dealing with a condition, a cardiac condition that is being managed in partnership with a physician, things like emergency contraception, you know, other types of birth control that you may not realize has some interaction with the medications that you're taking to manage your heart disease, really does need to be brought up, right, in the context of your visits with doctors. So Dr. Gaither, you know, I think what we see in the context of WomenHeart is that the women that come to our, join our community, become WomenHeart champions, as women with heart disease, are getting younger and younger, unfortunately. And yet they still want to, you know, have the opportunity to have children, but perhaps later in their lives. So therefore there is a real need for birth control. I mean, I know we've talked about, you know, all the things they need to consider. I guess my question is, you know, at what point is it appropriate for that individual to get to get their OBGYN talking to their cardiologist? You know, is there a right moment? I mean, could it be too early? You know,
Puberty.
Puberty.
Mm-hmm. Yeah, puberty.
It's never too early.
It's never too early. Mm-mm.
That's really important, because I bet that a lot of women go, I'll talk about it when I need it, or I'll talk, you know, we'll address it later on. So that's a really important thing. If you are dealing with heart disease, you need to get your OB talking to your cardiologist as soon as possible, right? As soon as you start puberty. So I think that's a really important, that's a really important tip. I also would love to get Dr. Gaither, Dr. Bello, your reactions maybe to what we've heard from Kimberly. I mean, there's so many stories within your story, Kimberly. There's so many facets of it. And I'd be curious to hear from our doctors about, you know, what aspects of Kimberly's story kind of, you know, spoke to you and talk, you know, in terms of the need for more conversation and more awareness for women who may be dealing with similar situations.
Well, as a maternal fetal medicine specialist, she gave me angina just listening to the story. I have to say that. She had a very difficult case. You know, I'm not quite sure how the interplay was as far as the different physicians were concerned, but there were a lot of moving parts there, and which not only served to impact her, but also, you know, her developing baby. So, you know, again, it's important to have a very close and communication with the different physicians that will come in contact with somebody with this particular type of cardiac disease, and, you know, conjointly moving forward to develop a plan of action that would be beneficial and healthy for mother and baby. Dr. Bello, what are your thoughts?
First, I have to unmute myself, but no, I agree completely. And I think, you know, it sort of also ties into the previous question about when should you start talking about birth control. I think every person with or at risk for heart disease, any person who's pregnancy capable should think about birth control for them and what's the best option for them. And if you do know that you have heart disease or are at risk for it, don't be afraid to ask your doctor. If your doctor doesn't ask you what birth control are you using as part of that review of your medications and your medical and sexual history, please offer that up to them and say, you know, here's what I'm doing, or I could use some advice. I have high blood pressure. What do you think is the right medicine for you? And, you know, it may just not come into the forefront of their mind when they're thinking about all sorts of other things. But, you know, I would encourage folks on the webinar to really just feel empowered. It's your health, it's your future. Sometimes not becoming pregnant and becoming pregnant have different risks for different people. And, you know, it really, in Kimberly's case, hearing about all that she went through, and you know, when you're going through the process of a heart transplant, or if you have a heart transplant, and all the medications that go into it and all the interactions they can have with contraception, it's important to be proactive, and, you know, also get your doctors thinking about it so that we have a backup plan. You know, if what used to work isn't working anymore, we need to think about what's another viable option. And I'm sorry to hear it took so long, Kimberly, to find the right other option. The thought of bleeding for that long is, you know, oh, I feel lightheaded thinking about it. And, you know, I'm glad they found something that worked. And sometimes it does take a little bit of trial and error to find the right, safest medication or non-medication. Maybe it's an implant, maybe it's an IUD, maybe it is permanent sterilization for some folks who have now had a child or know that the risk of having a child themselves is so great that perhaps a surrogate or another option is something that would make their family complete. And, you know, those would be my thoughts.
Just to piggyback on what Dr. Bello said, and also to have a take-home message from what Ms. Connell said is you should know that pregnancy is nature's stress test. And if you have a cardiac issue, pregnancy can often deplete what little cardiac reserve that you have. So it's really important to take that into consideration, knowing that, okay, I have a pretty bad cardiac issue. Pregnancy is only going to make this worse and may potentially kill me. So I think that's an important take-home message.
Dr. Gaither, is that the kind of, I mean, it sounds to me like women with a cardiac issue need to seek that maybe difficult opinion, need to seek it out, right? If you're dealing with it, you need to go and ask that question. Because I can imagine women who might have heart disease, who are, who really want to be moms and who really want to birth their own children, and will do it even if there is risk. And you know what I mean? So I guess if I frame it into a question, how would they've got to take in all these different pieces of information, and they've got to make a decision that's right for them. And I can imagine that it'd be really, really hard for a woman with heart disease to hear it's advisable that you don't have children because of the heart disease that you have. So there's sort of a real important psychological component to this too, right? That this sort of acceptance that, what maybe I had been dreaming of for my entire life may not actually happen.
There's a lot of, just to piggyback on what Dr. Bello said, reproductive technologies are out there. So perhaps surrogacy might be an option if you want to have a family.
Yeah, absolutely. We've got another question. When do we recommend no pregnancy if risks are extremely high? I mean, I guess the point that we've just sort of discussed is that it's really case by case. You have to have frank conversations, know and be very well aware of the risks that the additional risks that your cardiac condition might pose to you as it relates to your reproductive health. I think that's what's really important here. We are sort of wrapping up, but before we do, I wanted to give each of our panelists an opportunity to share some last thoughts. Just thinking about, what is at once a really empowering thing for a woman to do is seek out the right birth control option, all the way through to a fraught conversation, perhaps with your provider, because you may be considering birth control now, but then thinking about pregnancy later. And then perhaps your heart issue sort of, precluding you, right, from having children, like all of that. I'm just imagining this real wild roller coaster of emotions that one goes through. So just sort of, I'd love some last words from each of you as we think about the complexities that women may not even realize they should be thinking about, as they consider these options for themselves. Let's start with Dr. Bello.
Great, thanks. I would say, I want people to feel, one, empowered to speak to their providers and make sure that their providers are talking to one another. Dr. Gaither talked a lot about the team, and it is a team sport, and the patient is in the center of that because it really needs to be driven by patient preferences with the advice of physicians who understand the medical complexity, but know that there are many options out there for contraception. And if one isn't working, don't be frustrated, but we can figure out other options for you. And I would say always have a backup plan.
Thank you. Great advice. Dr. Gaither.
Just to piggyback on what Dr. Bello said, a multidisciplinary team taking care of you. Again, if pregnancy is a thought of yours, know that, again, pregnancy is nature's stress test for your cardiovascular system. So, you know, be very knowledgeable as to what it is that you plan to do, knowing that if you have a condition that pregnancy is not advised, it can not only impact your health and your life, but also that of your unborn baby. So think and be wise in your decisions, because you potentially could be impacting not only your life, but your unborn baby's life.
Thank you, Dr. Gaither. And Kimberly, we'll give you the last word.
My last word is I'm grateful that there's like me and doctors on here as well, because the doctors give their professional advice, and then I'm the person that lived it as far as wanting to be a mother, heard what the doctor said, like having a doctor like Dr. Gaither was one of my doctors. I mean, she pushed it, she pushed it, she pushed it. I should not have a baby, you know, and I understand that, but it never took away the desire that I had. Like, it's kind of like you saying that, but you're not in my shoes to really know I long for this, I desire this, you know? And that's why I say it's such an honor to have both on the line, that can be able to speak for that person that felt like I did. And in that situation, I did it. You know, I went forth and done it. And although my son didn't make it, no one can take away that I became a mother, you know? So it's like, it was a bittersweet thing for me, but I would not personally advise it on anyone. I'm just the person that desired it, that wanted it, and had doctors to tell me the opposite. And it wasn't until I received my transplant and ended up healthy that I went on to have a child again. But I'm just grateful to, it's almost like it's taking me back to when I was that young girl hearing my doctor talk, and I went against all odds. And at that time, it wasn't the best thing for me to do. And it helped me understand why they were saying the things that they said to me, because it caused me a great pain. You know, I lost a kid because of it. So that's kind of my last words, just showing gratitude that reality and then doctors are on the line to be able to shed light on both.
Mm-hmm. You know, I so appreciate that, and I appreciate all of you. This panel, more than maybe most, shows me why we exist as an organization. You know, these are really difficult and challenging conversations to have. They are life and death conversations, and they are life and death considerations. And the big message is I'm taking away: pregnancy is a stress test. For as long as you don't want to get pregnant, even when you don't want to get pregnant, you have to talk to your OBG and your cardiologist, and they have to talk to each other, because the management of both your heart disease and your birth control impact one another. And that, you know, to Kimberly's point, there are real life choices that folks make that are really difficult, and that are you know, the lived experience that will only hopefully help others as they go through their own journeys. I want to thank the panelists. I want to thank a very lively discussion that we've had on the chats. You know, this is an ongoing conversation. We are here to have it. It's not easy, but, you know, I think by sharing at least, and by tapping into the expertise that we were able to tap into with Dr. Gaither and Dr. Bello today. And, you know, just in gratitude to Kimberly, you know, hopefully we've shed a little bit of light for those who might be struggling with similar decisions. So thank you all. WomenHeart, just in light of all of that we've just talked about today, WomenHeart has developed a new fact sheet on birth control and heart disease, and you can find that on our website at womenheart.org. Also, you can access stories just like Kimberly's from real women dealing with real situations that don't have easy answers, and yet they're here to share them with you to help you make good decisions about your own heart journeys. So thank you all, and we look forward to seeing you next time.